So hello guys, in this video we are going to talk about uterine transplant. So uterine transplant is just like another solid organ transplant like kidney transplant or liver transplant. So what we basically do here, we take out the uterus of the donor person and we implant the uterus inside the recipient. Basically, the indication for this kind of operations is called AUFI, also called absolute uterine factor infertility. Now, the uterine transplant is a novel surgery. It is not used too much in the world. Only some reported cases are there so far, but we know that it's successful. But there are some drawbacks as well, so we'll discuss all these things in these videos. Now, let's see what are the indication for uterine transplant in terms of what are the causes of AUFI, absolute uterine factor infertility. The causes are, first and the most important cause is MRKH syndrome. Basically, it's a Mullerian agenesis or Mullerian problem, Mullerian development disease. In such cases, sometimes the uterus is either completely absent or does not form at all, or uterus is very partially or dysfunctional present. Now the uterus is absent, or the uterus is not good in shape, or uterus is not enough or capable for pregnancy. This makes the largest bulk of the patients who are undergoing uterine transplant. The other part of this thing is we have to also see about other associated problems with MRKH. For example, some patients have kidney agenesis as well, so they most of the time they have only one kidney. So if this patient has done the uterine transplant, and if this patient becomes pregnant in future, the patient is already, you have only one kidney, and most of these cases end up into preeclampsia. So you see my point, uterine transplant is not that easy because it is not absolutely necessary for life. The core difference between the other transplant, let's say kidney transplant or liver transplant, and the uterine transplant is the uterine transplant, it is not absolutely necessary for life. The other difference is it is only temporary. So when we transplant the uterus, the purpose of this operation is to get babies, to treat the fertility. So when the fertility is achieved, when the patient delivers babies, then there is no use of keeping this uterus inside the body. So at that time the uterus is removed. So this is temporary, it's not permanent. So there are lots of difference, basic difference between these transplants. Now let's see, the other indication is post-hysterectomy. Sometimes after the postpartum hemorrhage, if it is a very major postpartum hemorrhage, and removing the uterus, or what we call hysterectomy, obstetric hysterectomy, is the only option to save the life of the patient. Now if such patients want to be pregnant in future, this operation is an indication. Okay, some of the diseases like cancer, very early stages of cancer, we do hysterectomy along with salpingectomy, along with oophorectomy. In this case is also, once the cancer is gone, they can be thought of doing uterine transplant. Other cause which is now increasing is Asherman syndrome. What is Asherman? Asherman syndrome is we have very non-functional or dysfunctional endometrium. The endometrium is absolute necessary for implantation and for having baby later on. So if the endometrium is not functional, that means the uterus is not functional. So Asherman syndrome is basically a problem of endometrium, the uterine cavity. There are some adhesions, or there is a very thin endometrium. Part of the endometrium is lost. So this patient also can be a candidate for uterine transplant. Now, as I said, it is not the absolute necessary for life. So all other options to treat the Asherman syndrome are tried first, then only go for uterine transplant. Okay. Now the transgender population, these people may want to be pregnant and they don't have uterus. So this patient can be also reasonably or ethically are candidates for uterine transplant. Now, as I said, uterine transplant is a last option. It's not the life-saving thing. You must know that with any organ, any solid organ transplant, the patient requires a long-term immunosuppression to stop the graft rejection. Now, with the uterine transplant so far, whatever the procedures have been tried so far, it is seen that 30% of these cases suffers with rejection, graft rejection. That means if you do the uterine transplant, if the 100 uterine transplant has been done, 30% of them won't survive because there is a very, very high rate of immune reaction against the graft. What we call it rejection, graft rejection. It is seen in 30% of the patients. Now we have to discuss about who are the donors and who are the recipients. We already discussed about the recipients, those patients with absolute uterine factor infertility. Those are the cases for uterine transplant. Now the donors can be either healthy or it can be either postpartum as well. But most of the cases, the healthy donors has been used so far. Now if we talk a little bit inside of the surgery, so what we removed from the donor, we remove the whole uterus, cervix, upper vaginal one third vaginal cuff, ligaments. What are the ligaments? The uterosacral ligaments, cardinal ligaments, even round ligaments. The arteries supplying the uterus. All this complex is implanted into the donor, not just the uterus. Now, the fallopian tubes. What about the fallopian tubes? Can the patient become pregnant naturally after uterine transplant? No. So this is not the case. Why? Because there is high risk of ectopic pregnancy, and when we have done this risky procedure, we cannot afford to have an ectopic pregnancy. So what we do, we remove the fallopian tubes after implantation. Remember, after implantation. We also don't go for natural conception. We almost always go for IVF, where we already made the embryos. Okay, embryos are ready made and cryopreserved. They are ready to be transferred once the uterine transplant has been done. When we talk about the obstetric outcome, almost all cases has been gone under cesarean section. Okay, because we don't know how the uterus will act while being pregnant, while in labor. So definitely all of the patient goes for cesarean section. As I said, tubes have been removed after the implantation. Now, embryo transfer, which is basically a assisted reproductive technology. The embryo transfer can be done earliest at 6 months after uterine transplant. That means once the lady has undergone the uterine transplant, we don't do embryo transfer immediately. We at least wait for 6 months, and ideal time is 1 year. After these years, we see that if the uterus is doing good, if the graft is doing good, then only we go for pregnancy and therefore embryo transfer. The immunosuppressant, it's a very, very important here because now we are dealing with pregnancy. We cannot use many of those immunosuppressant drugs meanwhile the patient is pregnant, and immunosuppression always continue in pregnancy as well. So we have limited options. Those options are steroid and tacrolimus. These are considered safe in pregnancy, and that's why this is used. Okay, now as I said, the unique thing about uterine transplant, first of all, it is not life-saving, and other is temporary. Once the pregnancy is achieved, once the patient has enough pregnancy, some patients want just not one pregnancy, they want 2 pregnancies. That's also be done. So if the family is complete, then the uterus is removed later on. Okay, now first of all, what is a traditional treatment for uterine factor infertility? The traditional measures are adoption and surrogacy. Now there are a lot of things legal issues, ethical issues, psychological issues associated with adoption and surrogacy. I mean, not in all countries the rules are same, the law is same. Some countries may not even consider surrogacy or adoption as a legal thing. There are religious factors as well, cultural factors as well. So all of these factors, has to be addressed before we go for uterine transplant. And a very nice, good conversation with the patients. It's not just one conversation; it needs to be prolonged series of conversations and counseling to the patient, so that they know all the risks associated with this procedure. They always also they know the success rate of the procedure. Or, for example, what is the success of uterine transplant? The success is not just uterine transplant. The success is all over healthy pregnancy or the baby in the hand. This is what the prime goal for uterine transplant. So whether we are going to achieve it or not, because the embryo transfer success rate is not more than 35%. So even if you have a uterine transplant, the uterus is working fine, the graft rejection is not there, patient is doing good, but the all over success rate of the embryo transfer is 30 to 35% in one go. Okay, so I mean, it's not a 100% successful procedure. Some patients might think that why to take so much of risk when it is ultimately not a guarantee of success. So it is all are the factors which are important before we actually even try to think about the uterine transplant. So this is the most important part here. So I would say this is all about this video. I think it's in such a short of time you got enough information, basic information for the uterine transplant. I hope we'll make a detailed video on that in future. Thank you very much.